Hello, everyone, and welcome to today's webinar, PCT, an Aid to Antibiotic Decision Making. I am Michelle Ashton of LabRoots, and I'll be your moderator for today's event. Today's educational web seminar is presented by LabRoots and brought to you by Thermo Fisher Scientific. To learn more, visit thermofisher.com. Let's get started. Before we begin, I would like to remind everyone that this event is interactive. We encourage you to participate by submitting as many questions as you want and any time you want during the presentation. To do so, simply type them into the Ask a Question box and click Send. We'll answer as many questions as we have time for at the end of the presentation. If you have trouble seeing or hearing the presentation, please click on the Support tab found at the top right of the presentation window, or report your problem by clicking on the Ask a Question box. This presentation is educational and thus offers continuing education credits. Please click on the Continuing Education Credits tab located at the top right of the presentation window and follow the process to obtain your credits. I'd like to now present today's speaker, Dr. Trevor Van Schooneveld, Associate Professor in the Division of Infectious Disease, Department of Internal Medicine at the University of Nebraska Medical Center in Omaha, Nebraska. For a complete biography on our speaker, please visit the Biography tab at the top of your screen. Dr. Van, you may now begin your presentation. Welcome.
Thank you. Thank you for having me. Today I'm going to talk about procalcitonin and its utility in helping us make antibiotic decisions. These are my objectives. At first, we're going to talk a little bit about the biochemistry and the physiology of procalcitonin, the kinetics, how it works. We're then going to look at some of the literature on how it can be useful in lower respiratory tract infection and sepsis. We're going to talk a little bit about how it can be utilized with the current viral coronavirus pandemic based on the currently available literature. And then we'll talk at the very end some best practices on how to implement if you haven't, and how to utilize more effectively and efficiently. Now I want to start off with a poll question. This is a case that I saw. A 30-year-old male has diabetes type 2, presented to the ED with fever, cough, chills, nausea, vomiting, and body aches for 3 days. He said it felt like a truck had run over him. Now, this was a couple years ago, not right now. We'd all think he had COVID maybe right now. His white count was normal. Lactic acid was normal. His chest x-ray showed bibasilar pulmonary opacities. The radiologist said suspect developing consolidation. His rapid flu is positive for influenza B. And so we have a poll question that we'd like you to ask. Would you start antibiotics in this patient? And so that poll question should pop up for you to answer. All right, so we have a diabetic. He has fevers, coughs, feels terrible. He's positive for flu, certainly sounds like flu. And the poll basically shows, I'll send you the results, 77% said no, they wouldn't start antibiotics. So let's go on to the next slide. What if I told you his procalcitonin was 0.75? So we're just going to ask the exact same question, would you start antibiotics? Same patient, same exact presentation. We now have a procalcitonin of 0.75. So 81% now are saying yes, that they would start. And so I think it's interesting to see that. I always like to start out with that to just see how people would interpret and what they think of procalcitonin. This is, I think, a great example of where procalcitonin can have some utility. Because generally it's say, flu B, they feel crummy. That's kind of what we expect. What I'll tell you is This gentleman overnight grew Group A strep in his bloodstream, but he had gotten started in antibiotics and typical CAP antibiotics and actually did pretty well and was home in about 2 or 3 days. But he definitely had a bacterial infection. So let's talk about procalcitonin. So we all can probably acknowledge that antibiotic use is not optimal, suboptimal. A lot of use in the hospital that's either unnecessary or inappropriate. It's a big driver of resistance. It causes toxicities, renal dysfunction, C. diff, you name it. We use a lot of antibiotics that we probably don't need to. And why do we do that? Well, it's actually because the diagnosis of bacterial infection is kind of hard. Right? If you look at sepsis studies, diagnosis of sepsis, I mean, the gold standard of sepsis is really we gave some antibiotics because we thought they had an infection, they got better. Pretty rare we find the etiology of sepsis, somewhere around 30 to 60% of the time. The cultures are often negative or they just grow contaminants and they get better. And we say, well, they must have had an infection and know it's sepsis. Similar with pneumonia. The clinical diagnosis of pneumonia is difficult. The etiology in the very aggressive diagnostic studies is only determined up to maybe half the time, usually much lower. Blood cultures have a really low yield, so low that the recent CAP guidelines suggested that they be abandoned except in severe CAP. Similarly, sputum culture and gram stain. A lot of people can't produce it. And then once you start antibiotics, rapidly makes it, we can't detect a lot of the pathogens. So it actually is really hard to diagnose bacterial infections. And so we use biomarkers, right? And what are biomarkers? Biomarkers are measurable characteristics that reflect the severity or presence of some disease state. Currently in infection, we use things like fever, white blood cell count, CRP. These are the biomarkers we use. Now, the ideal biomarker of infection, and it doesn't exist yet that we know of, is sensitive, doesn't miss anybody with a bacterial infection, and it's specific. It's not positive in people who don't have a bacterial infection. It'd be nice in this ideal biomarker if the higher it was, the more likely it was that someone's infected. And so a 0.2 would mean something less different than a 2, and a 20 would mean something different than that. It'd be nice if when we treated somebody, that biomarker went down and reflected sort of the progression of the infection. And it'd be really good if it wasn't confounded by immunosuppression and other conditions, which are a lot of the problems we have with our current biomarkers. And then any biomarker to be useful has got to be fast, so we can use it to make decisions, and everything needs to be cheap these days, right? So the ideal biomarker does not exist. What I will tell you is right now, procalcitonin is the best, and this is just my opinion, the best biomarker for bacterial infection that we have. Is it perfect? No, but it's the best we got. Procalcitonin under normal physiologic conditions. So procalcitonin is a product of the calc gene. The calc gene is actually usually used to produce calcitonin. It produces this precursor peptide, which is then processed in the Golgi apparatus and secreted under this highly endocrine regulated system of gastrin and calcium and a bunch of stuff that I don't remember anymore from medical school and residency. And it's produced by a few small cells in the thyroid gland, and normal physiologic conditions are just picogram levels of procalcitonin. Now, what happens is under bacterial infection state, where there's lipopolysaccharides and the inflammatory cytokines released by bacterial infection, there's what people may term a hormokine production of procalcitonin. That means sort of all over production, where that same gene is transcribed, but doesn't have the post-translational modification in the Golgi apparatus, and is just secreted as calcitonin, and it's secreted rapidly, and it's secreted from many tissues. Interestingly, that production is generally inhibited by the cytokines produced by viral infection like interferon gamma. What tissues produce procalcitonin? Well, under normal physiologic states, which is healthy, thyroid and a few of those neuroendocrine cells in the lung, but under sepsis or other inflammatory states, it's a whole host of tissues. And so you can't really remove the tissue or the cell line that produces procalcitonin, which is one of its advantages. It's also more widespread than cytokines. Cytokines do stimulate its release. It is driven by cytokine release. This is data generated through lipopolysaccharide experiments when they inject lipopolysaccharide and measure cytokines and other biomarkers. What you can see here is the first thing to rise are the inflammatory cytokines, IL-6, IL-10, TNF-alpha. Procalcitonin follows soon after that. The cytokines have not quite yet been useful as biomarkers of infection. It may be in the future we'll have a panel of cytokines and procalcitonin or other biomarkers that will help us even more than any individual marker. But right now, the cytokines just aren't very practical in sorting this out. You can see procalcitonin levels rise within 6 to 12 hours and typically hit their peak by about 12 hours after the inflammatory insult. once that inflammatory insult is removed, the infection is removed, the levels begin to decline. And they decline in a relatively predictable way of about 50% every 24 hours. That's a rough estimate. You can see CRP does the same thing. It's just more delayed in its response. Something to know about procalcitonin, because it's produced by systemic cytokine release, it's not really produced when you have localized infections like localized abscess or cystitis or osteomyelitis. And while those can produce fever, they just don't generally produce the level of systemic cytokines needed to drive procalcitonin. So that's something to keep in mind. It's not really useful for those localized infections. The dynamics of procalcitonin are very important. And this is something that I think it's very important for people to understand, is that while an individual value is useful, a couple of values can be even more use. And we'll talk later a little bit about how that is. The nice thing about procalcitonin is its dynamic reflects what's going on with the patient. These are patients, neutropenic patients actually, who had bacteremia or severe sepsis, and what you can see is those who responded to treatment, they were getting better. The procalcitonins came down nicely. Those where they weren't responding to therapy, the patient wasn't getting better, procalcitonin didn't go down and actually appeared to be going up. And that dynamic of procalcitonin decline or non-decline or rise is actually predictive of outcome. Been a number of studies that have looked at this. This is one that looked at ventilator-associated pneumonia, and they compared people who survived and those who didn't. Those who survived, their procalcitonins were elevated, but then dropped. The sort of initial procalcitonin wasn't really predictive, but it was really that dynamic. Those who didn't survive had actually rising procalcitonins at day 4. And this is actually a prognostic marker for sepsis as well. Those non-declining procalcitonins are not a good sign. And so just to briefly summarize what I could have talked about an hour on is that procalcitonin is produced ubiquitously after cytokine production produced by bacterial infection. It's the most specific, and we'll talk a little bit about this in a little bit, biomarker for bacterial infection currently available. The levels rise rapidly, they decline predictably. Non-declining procalcitonin certainly can indicate a lack of infection control. And we won't talk much about this, but that is sort of the way I think about it. I'm treating an infection, the procalcitonin is not going down. It makes me reevaluate things. Do I need to switch therapy? Am I missing something? If the patient's getting better, I generally just kind of sit tight and monitor. But if the patient's not getting better and the biomarker's not getting better, I start to get kind of nervous. I'm missing something. And it's not impaired by neutropenia or other immunosuppressive states generally. Now, there are some things that can confound your procalcitonin, and it's really important you understand these if you're going to utilize procalcitonin. Any sort of massive physiologic stress, because it results in cytokine release, is going to cause procalcitonin release. And so it turns out being born is a major physiologic stress. Now, procalcitonin is not approved for use in neonates, although there are centers that do use it. Generally, when they use it, anything before 72 hours after birth, they don't usually use because being born is stressful, apparently. And after that, usually it's recommended to interpret as usual. Any sort of major physiologic stress, trauma, major surgery, cardiogenic shock, CPR, burns, any of that stuff is going to cause a release of inflammatory cytokines and a rise in your procalcitonin value. What will happen, though, is if you resolve that, it should trend down back to normal. And I could show you numerous studies, but I don't have time to do it, looking at post-cardiac surgery, post-transplant surgery, where after surgery, the levels go up and then decline nicely back down to normal at about 50% per day. Any sort of prolonged, severe, non-resolving physiologic problem or organ perfusion abnormality, like cardiogenic shock that's not getting resolved or ischemic bowel that's not being fixed, can cause procalcitonin rise. And that's because we have, again, ongoing release of inflammatory mediators, perhaps leak of lipopolysaccharide, and it just doesn't go down until you really fix the problem. That doesn't necessarily mean the infection is out of control. And so you just have to keep those things in mind, particularly when you're evaluating your complicated ICU patients or your post-surgical patients. And that's where the dynamic can be very useful, particularly in your post-operative patients. If the level's declining, that's helpful. If it's rising, that's concerning, but you kind of have to have the trend there. There are some non-bacterial cytokine activation syndromes that can cause procalcitonin to go up. Some forms of vasculitis and acute graft versus host can cause this. Malaria and fungal infections can cause this. And then chronic renal disease can cause mild increases in procalcitonin. And the way that I usually think about this is chronic renal disease is a pro-inflammatory state. And if you measure lots of different inflammatory markers, they're all mildly elevated in chronic renal disease and end-stage renal disease. And so procalcitonin is one of those. Now, how high is it? Well, it tends to run in the 0.25 to 0.5 and maybe up to 1 range. But the really lows are still useful. Like if it's negative, it's still negative. And the really highs, typically I think of anything over 1 to 2 as high. That's still pretty useful. Those sort of in-between values can be a little difficult to interpret in these patients. And again, the trend can be more useful there. And then there are some dysregulated syndromes where you give agents that stimulate cytokines, like some of our organ transplant induction agents and IL-2 and granulocyte transfusions. And then a paraneoplastic syndrome for like medullary thyroid cancer or small cell lung cancer, where you're producing calcitonin, is going to have a lot of procalcitonin produced. So those are confounders. Really important you understand those and think about those and use those when interpreting procalcitonin. Now, I am not going to show you any of the diagnostic studies on procalcitonin. There have been a plethora, many, 50, 70, lots. And there's a reason for that. So the way that we evaluate diagnostic markers, and I've sort of built this diagram to show it, is first we do observational studies where we take 100 people with bacteremia and we measure a level of procalcitonin, whatever biomarker you want to measure. After we've done a bunch of those studies, we combine them into a meta-analysis and we say, this is how good this is. There's sensitivity, specificity, positive, negative predictive value. The problem with all of those studies is they generally are observational and they don't look at the impact of the actual diagnostic test. They also use varying gold standards of diagnosis. And we've already talked about how poor our diagnostic gold standard is in pneumonia and sepsis. They use different cutoffs. Some of the studies in procalcitonin use different assays. They're done in very different clinical settings, and there's a huge amount of selection bias. And this is the main problem, I think, with diagnostic studies, is they pick people we already know have the diagnosis. When we use diagnostic tests, we pick people we think might have the diagnosis. We don't know that if we knew they had bacteremia, we wouldn't need the diagnostic test. And so what's really useful, and I think relatively rare in the diagnostic testing literature, are to do randomized trials where we take a clinical problem and we randomize people to utilization of a diagnostic test or to not utilizing that diagnostic test. And the interesting thing is, in procalcitonin, we have a bucket load of randomized controlled trials, so many that we can do a bunch of meta-analyses. And so, we're not going to talk about these observational studies. There have been at least 5 or 7. I can't even keep track of the number of meta-analyses looking at the sensitivity, specificity, positive, negative predictive value of procalcitonin for diagnosing infection. But what really we need to know is where the rubber meets the road. What happens when I use it to make decisions? That's what really matters. And that's where I think we really, in procalcitonin, have the data. In a lot of other diagnostic tests, we don't have the data. I have down here a citation for what I think is one of the better meta-analyses on this topic. The discussion is actually what I really like here, because they talk about how procalcitonin is not also not a dichromatous test. It's not a positive versus negative. It's a test where 0.2 means something different than 2, which means something different than 20. And you can't take that into account in the way that we statistically evaluate tests, likelihood ratios, and the sensitivity and specificity. It's very difficult. So, where are we going to talk about? Well, the best data on procalcitonin is in respiratory tract infections and sepsis. Here are a list of other areas where it's been studied. Some have better evidence than others. What I would say is that the best evidence is in what I'm going to talk about, but you can find data in all these other areas. And so let's talk about lower respiratory tract infection first. So this is the first randomized trial done 16 years ago. What they did was they took patients presenting to the ED with lower respiratory tract infections, pneumonia, acute bronchitis, exacerbations of chronic bronchitis, etc. They did a single-blinded trial where in one group they randomized them to PCT-guided antibiotic use. In the other group, they said, you just do your thing. They had a PCT algorithm where if the level was 0.5 or less, they discouraged 0.25 or less, they discouraged antibiotics. If it was over 0.25, they encouraged it. And depending on how low or high it was, they might have more strongly discouraged or encouraged. If antibiotics weren't started, they recommended repeating it at 6 to 24 hours, and they allowed physician overruling because we always want to treat patients and not lab values. That's how we make decisions. And every study of procalcitonin has allowed physician overruling. And in this study, it was about 18%. What did they find? Well, their clinical outcome, and this is the key question, can we decrease antibiotic use safely without hurting a bunch of people? And in this study, they did. They decreased antibiotic initiation, and a bunch of people didn't die because they didn't get antibiotics, which is often the reason people start antibiotics. Well, they might get worse. They might die if I don't give antibiotics. They'll die of sepsis. And so we give antibiotics. We don't think some of those people probably need them, but that's what we do to be on the safe side. And so in this study, there was no difference in mortality, no difference in length of stay, but antibiotic prescriptions dropped by nearly half, and antibiotic days of therapy dropped by about half. What you can see is in conditions where antibiotics were rarely needed, like asthma, bronchitis, acute exacerbations of bronchitis, most of those people don't need antibiotics, but maybe a couple do. And that's where they had the greatest benefit, and that they cut antibiotic use a lot. But even in community-acquired pneumonia, they decreased it significantly, so about 10% overall. We know there are viral pneumonias out there, and they don't benefit from antibiotics when they have a virus. And so even in that group, there was some benefit. There have been a variety of other trials. There's probably been 15 or 20 trials in lower respiratory tract infection. I'm going to show you the largest trial. So the multi-center non-inferiority randomized trial for adults presenting same thing, lower respiratory tract infection to the ED. They had 6 facilities, enrolled over 1,300 patients. What they did here was not only do procalcitonin levels at admission, but also on day 3, 5, and 7. And they used a very similar algorithm. As you can see, less than 0.25 don't give antibiotics, more than 0.25 give them. They had some things like, hey, if they're super sick, you should probably just start antibiotics. They had some little nuances around COPD and severity of illness. And then they said, if the procalcitonin on day 3, 5, or 7 is less than 0.25, you should stop the antibiotics. Or if it's declined to about 80 to 90% of the peak, off the peak, you should stop antibiotics. So if it was at 20 and now it's at 2, you can stop antibiotics. What did they find in this study? Well, compliance here was about 91%. Overall antibiotic exposures were reduced by 35%. Again, it varied. Least decrease was in community-acquired pneumonia, about 30%, but in COPD it was 65%. The overall antibiotic prescription rate declined by 12%. Mean antibiotic exposures decreased 3 days, and we gave less antibiotics and saw less antibiotic adverse events. And we didn't see any increased other adverse events like readmission, empyema, recurrence of infection, and actually it kind of favored the procalcitonin side. And there was no difference in mortality, which is always what you want to see. We're using less antibiotics, but we're not killing people. This is a meta-analysis, and I think this is the best, most recent meta-analysis. And what this is it took all of the trials, 26 trials, 6,700 patients with lower respiratory tract infection. They were all randomized trials. Now, they occurred in varying settings, mostly hospital and ED. That was about 85%, CAP, HAP, VAP, bronchitis, COPD exacerbation. But there were some clinic patients included in that, and upper respiratory tract infection. And they did a patient-level meta-analysis, which is a little different than a regular meta-analysis, which just takes study outcomes and combines them. In the patient-level meta-analysis, you take the individual patient outcomes, and you combine them into a single study. And so it's a little more robust way of doing it. And what you can see is they were able to decrease antibiotic initiation at each time point and overall antibiotic use by about 2.5 days. Now, the really interesting finding in this study was people who were in the procalcitonin group actually had decreased mortality compared to the usual care group. And so why was that? Well, there was a question, was there less actual treatment failure in the procalcitonin group? Length of stay didn't differ. There definitely were less antibiotic side effects. And so why do we see this mortality difference? Well, there's a couple thoughts on this. We don't actually know the reason. One of the thoughts is less antibiotics may be better for patients. Less side effects, less toxicity, less C. diff, less renal dysfunction, less multi-drug resistance. And so that's probably good for patients. Another thought is procalcitonin helps to point us in the right direction, in that if you have a bacterial pneumonia, you want to give antibiotics and maybe IV fluids. If you have heart failure, which can look very similar with tachycardia and tachypnea and infiltrates and shortness of breath, and maybe a mildly elevated white count, that doesn't benefit from antibiotics, and it definitely doesn't benefit from fluids. It needs diuretics. And so there's a question of, is procalcitonin telling us it's not infection, go look for other stuff, and helping us to treat other stuff by not sort of always saying, hey, we should just give some antibiotics and some diuretics. It's actually a really interesting study that I don't have in here where they looked at antibiotic use in patients with heart failure and atrial fibrillation. What they found is people with AFib, where they clearly had AFib, still got lots of antibiotics because people thought it was pneumonia. And you may not know this, but antibiotics contain a lot of sodium. And so those patients needed longer in the hospital, needed a lot more diuretics, and there were actually some really negative side effects of not treating the condition correctly. So I think that may be a possibility, although I wouldn't say it's been clearly identified. Also, there may be some benefits of sort of customizing this. Some people could get a lot shorter, some people could get longer, but I think it's left to be sort of elucidated, the mechanism for this. These are the algorithms we use at our institution. They're very similar to those pro-hosp algorithms. Less than 0.25 don't give antibiotics, greater than 0.25 do. We recommend repeating every 2 to 3 days. We don't do them daily in lower respiratory tract infection. Certainly if people are really sick, you can start antibiotics and just monitor. If you don't start, it's reasonable to repeat in 6 to 12 hours if you're concerned about bacterial infection. And then we use a similar algorithm for follow-up, where if it's less than 0.25 or drop by 80%, we encourage discontinuation. Now, if it's rising or not adequately decreasing, that's where we sort of say, hey, let's take a second look and make sure we're not missing anything. And so just some conclusions from these respiratory tract trials. PCT-based antimicrobial use decreases antibiotic use without any adverse clinical outcomes, and there's a suggestion it may improve outcomes. Its effect on antibiotic use really varies based on underlying patient population. Is it the ICU versus outpatient? And frankly, the disease state, CAP versus COPD exacerbation. And I don't have time to show you the data, but it is a little variable in its impact. What about sepsis? So sepsis is really a dilemma. These are my two Venn diagrams for sepsis, both the old one and the new one. Sepsis is not an infection. That's what I try to tell our residents. Sepsis is not treated with antibiotics. The infection that's causing sepsis is treated with antibiotics. But in fact, the only sepsis-specific therapy we actually use are fluids and pressors, and we actually don't have anything to treat the underlying problem of sepsis. It's a non-specific diagnosis, right? It's organ dysfunction in the setting of, I think they might have an infection. Cultures take time, so we give lots of antibiotics because we don't want to miss, because we know people with sepsis have bad outcomes. And so we accept the negative of giving lots of antibiotics to some people who don't need them because we think we're going to benefit people in the long run. Now, all that use leads to toxicity, superinfection, resistance, and so we need some tools to help us make some decisions. This is the largest multi-center, well, not the largest, one of the larger trials looking at multi-center randomized trial of sepsis treatment with procalcitonin. Very similar to pneumonia. The one thing I'd point out is they used a cut point of 0.5. Why did they use a cutoff point of 0.5 to say give or don't give? One of the reasons is procalcitonin has been approved for diagnosis of sepsis at a level of 0.5 for many years. That seems to sort of be the better cut point for the ICU. Excuse me, and that's probably because there's just more inflammatory sort of milieu in the ICU. And so we're improving the specificity of the test while trying not to degrade the sensitivity, if that makes sense. You remember shifting your curve so you can improve your test performance. In this trial, they had similar things. They took patients who were admitted to ICU with sepsis, who were going to get started on antibiotics. They did a procalcitonin. They said it was greater than 0.5, start. If less than 0.5, don't start. And then they had a similar rule for stopping. They found overall antibiotic exposure was decreased by about 2.5 days. There was no difference in mortality. Adherence was way lower, like 50%. And so seemed to have some benefit, although certainly not the same benefit that we saw in lower respiratory tract infection. And so to follow that up, there was another randomized trial. And this is a multi-center randomized trial evaluating not PCT initiation, but only PCT discontinuation. The reason they did this is it's really hard for the ICU doctors not to start broad spectrum, not to start some antibiotics in their really sick patients. And I understand it's really hard for me to say, hey, don't start antibiotics in somebody who's gotten really sick. They tend to just start, whether, no matter what things say. And so this trial looked at discontinuation. And it was done in Dutch ICUs. And it's important to understand that it was done in Dutch ICUs. Why is that important? The Dutch are very conservative in their antibiotic utilization. They use less antibiotics than, many other countries in Europe. They use less antibiotics than we do in the US. They use less broad spectrum. They use shorter durations. And so one of the arguments against procalcitonin was, hey, we're already using way too many. If people just use less antibiotics in general, it probably wouldn't have a benefit. And so again, they took patients to ICU or admitted with presumed infection, and they did procalcitonin for stopping. So they measured it when they came in, but they didn't say to stop unless the PCT dropped to less than 0.5 or to decrease from 80% from the peak. And then they said, hey, we think you should stop antibiotics. What was the result of this trial? Well, they decreased antibiotic use. And then interestingly, they actually found decreased mortality. These are the actual outcomes. You can see whether it's defined daily doses or duration of therapy. It was significantly decreased in the procalcitonin group from standard care of 7, which is a pretty conservative standard for ICU duration of therapy for sepsis, pretty right on with the guidelines, to 5 days, which is shorter than the guideline. Length of stay was no different, but interestingly, again, mortality was different. So I think the same things, I think, with mortality, but particularly here, continued exposure to broad spectrum antibiotics and numerous other studies not looking at procalcitonin have been associated with bad outcomes in the ICU. So this is a meta-analysis of procalcitonin-guided antibiotic therapy in critically ill adults. I would say it's a little bit more homogeneous, with the I-squared being 0, but generally decreased antibiotic use. It was weaker strengths, didn't change length of stay, and interestingly, in this meta-analysis, adherence didn't really influence outcomes. And so I think my opinion is just my opinion. These are our guidance. And so we use the same algorithm, 0.5, less than 0.5. But we have this big red box that says, hey, if your patient's really sick and you think they have an infection, probably reasonable to just start. And then monitor every day or two. And when it drops to less than 0.5 or greater than 80% of the peak, you should stop. And so that's sort of been our strategy. I think for sepsis, really very useful, I think, for getting people off of antibiotics a lot earlier, even at 48 hours, because that's often what happens is they get started on antibiotics because nobody knows exactly why they've crashed and burned. The procalcitonin stays low. You have good evidence that stopping antibiotics in those patients is safe, unless you've found some specific infection. And so at 48 hours, 72 hours, that should really be pushed on instead of saying, let's give them 5 to 7 days because they got better on antibiotics. And so there are some issues with the sepsis studies. They do have a lot of overruling. I will mention in that Dutch study, it was 90% compliance at 24 hours after the recommendation. There are selective populations with different problems. The renal dysfunction issue does come in here with acute kidney injury and some of those mid-range values. But my take on this is procalcitonin-based treatment appears safe, particularly when we're using it for antibiotic discontinuation. And patients with PCT values that have normalized or decreased significantly should really think about stopping antibiotics. Now, when is procalcitonin not useful? Well, we talked about localized infection. That's one place. I want to talk about the PROACT trial, which is a large U.S., which is unique in that most of those other trials were done in Europe, U.S. randomized trial of PCT use in lower respiratory tract infections, done at 14 hospitals who not previously utilized it. They introduced it using sort of a QI process, and they randomized to PCT-guided or usual care. They enrolled over 1,600 patients over a couple of years. They had about half of those patients hospitalized, about a third were COPD, a quarter were acute bronchitis, and only about 20% were CAP. Now, what they found in this study was that procalcitonin didn't decrease antibiotic use at all in any way that you measured it. Now, what I would point out is that the usual care antibiotic duration of therapy was 4 days, which is really low and much lower than any of the previous trials that had ever been published using procalcitonin. Their control groups had been much higher. 91% of patients had a procalcitonin value less than 0.25, suggesting most of them didn't need antibiotics to start out with. They also enrolled a lot more of the non-severely ill and low prevalence of community-acquired pneumonia compared to a number of the other trials I showed you. And so my conclusion from this was not that procalcitonin doesn't work, but that in a patient population where I'm already going to use a really short course of antibiotics, it probably isn't going to shorten it up much. If I'm going to give only 3 to 5 days of antibiotics, it may not be useful. And the new community-acquired pneumonia guidelines recommend against the use of procalcitonin to decide duration of therapy. They say give everybody 5 days, which if you give everybody 5 days, makes some sense. But at our institution, I wouldn't say 5 days would be kind of unusual for a CAP therapy. So if you really are going to use short courses of antibiotics, I agree, procalcitonin may not decrease antibiotic utilization. If you already think it's really unlikely this person has a bacterial infection, or I'm 100% confident they have bacterial infection, it may not be useful in helping you to diagnose them. But most of us operate in areas of some uncertainty. And so I think it still has some utility. All right, I want to mention a couple things on PCT and COVID. And so I put this disclaimer here because with all things COVID, we could rapidly revise everything we've said when new, better literature comes out. But what I would say from my review of the literature as of a couple weeks ago was that PCT values in COVID are generally low. The median PCT value in 5,900 cases in New York City was 0.2 and ranged generally from 0.1 to 0.6. Now, the CRP, in contrast, was pretty high. And so CRP seems to be something that goes up a lot higher in COVID than the procalcitonin. Now, procalcitonin values do vary based on severity of illness. And the sicker you are, the higher your procalcitonin values are. And interestingly, that value may actually be predictive. And I'll show you that here in a minute. But this is just some data from hospitalized patients with COVID. It was a much larger population, but a big chunk of it they didn't have final outcomes on, and so this is what they had. What you can see is those who survived generally had lower procalcitonin values. Those who died generally came in with at least some mild elevation. These are PCT values in moderate to critical COVID-19. What you can see is those with non-severe disease generally had relatively low procalcitonin values, almost always less than 0.5. Those with severe, critically ill patients had higher values, but again, not that high. Those who were discharged generally had decreases in their procalcitonin, while those who died had their procalcitonin rising. And so elevated procalcitonin do seem to predict for bad outcomes. There already have been, and I was amazed at the number of meta-analyses already available on different biomarkers in COVID. 45 studies with 4,200 patients and elevated, whatever that means, procalcitonin in this study predicted ICU admission, but not ARDS or mortality. Where in this study, a different meta-analysis, it was associated with a combined poor outcome of mortality, severe disease, and ICU, and particularly a procal greater than 0.5. And it looked like it may have actually been better than CRP or some of the other biomarkers, but who knows on this one, which biomarker is the best? My own opinion is you should pick one biomarker and go with it. But it seems to be a marker if it's elevated for a worse outcome. Now, is that because those patients also have bacterial co-infection or it's something with COVID? I don't know the answer to that. This is just a nice study that looked at empiric antibacterial therapy and co-infection in COVID, because that's sort of the concern. These patients all present from the community. They have infiltrates, they have fevers. They might have bacterial infection or they might have COVID. This is a random sample of 1,700 patients who had COVID in Michigan. They looked at early antibiotic use only and bacterial co-infection. Over half of patients got antibiotics, and they defined a bacterial co-infection in 3%. And so bacterial co-infection at the time of presentation is relatively uncommon. In fact, I'd call it very uncommon. The predictors of bacterial infection were being older, from a long-term care facility, malnourished, having kidney disease, or being really sick, or having leukocytosis. They measured procals in about half the population. A level of 0.5 was actually the strongest predictor for bacterial infection. But about 20% of those with over 0.5 didn't have a bacterial infection defined. Is that because they couldn't define it and they had one, or because they really didn't and it was just bad COVID? We don't know. PCT of less than 0.1 had a negative predictive value of almost 99% for bacterial infection. So again, I think the level is useful. If it's really low, probably not a bacterial infection. If it's over 0.5, it probably is. If it's in between, it's a little hard to know what to say, because could it be bad COVID? Could it be bacterial? I think there you're sort of watching the trend and trying to make some decisions based on your testing results. So it's a little tricky as the literature emerges to know how to interpret it. Couple last comments on implementation, and then I'll go through a couple cases. So if you have procalcitonin or thinking of implementing it, I think it really helps to have a local expert, somebody that people can ask questions of. Somebody can say, hey, I got this. What do you think? What do you think's going on? Whether it's in the lab, pathologist, whether that's an ID physician, whether that's a stewardship pharmacist, somebody. It's good to develop recommendations of what to do and how to use it and how to interpret it. Not just put a value out there that turns red when it's some number, but it's good to like tell people what you think they should do. Because this lab does require a little bit of interpretation. It's, I think, good to encourage people to use it where it has utility, because lower respiratory tract infection, sepsis, and don't use it where it doesn't. Cystitis, localized abscess, UTI. There's a little literature out there, but I would say it's not ready for prime time in this area. I would look at processes to avoid inappropriate or unnecessary use. So we don't allow people to order daily procalcitonins. Because, we looked and some patients had 30 procalcitonins over 30 days, which means no one's doing anything with that data. And so that's just a waste of blood and a waste of money. And so you want to have some sort of process to help make sure it's used appropriately. I think it's useful when you're presenting the data to not just put it in your lab report, but to put it where people look at infection-related data. We have a screen where we have fever and white count and procalcitonin and antibiotics and culture results. And it's all sort of a one-stop shop for all your infection-related data. And so I think it's useful to put it there. And then I think having a stewardship team involved can help with this. In one study where there's a local stewardship team plus a PCT algorithm, they were able to decrease antibiotic use by about 20%. And then in another study where they looked at community hospitals where they had PCT available and compared to community hospitals where they didn't, they saw decreased length of stay and a non-significant decrease in antibiotic use was 1.5 days, and they had a shorter length of stay. Now, is that all from procalcitonin? Hard to tell. Those places with PCT also had pharmacist-driven algorithms. So there is suggestion that, combining these with stewardship really is probably the best way to do this, as it is with like all the rapid diagnostics for infection. So key points, the dynamics are very important and very useful. You want to keep in mind the confounders when interpreting. You want to use them in syndromes where they have data, lower respiratory tract infection, sepsis. Don't use them where they don't have data. Don't use them if you're not going to use it, right? Why get a lab you're going to ignore? And so don't bother getting it if you're not going to do anything with it. And this is what I always tell my residents. If the test will not change your treatment today, why are we doing it? And then usually we don't recommend testing more than every 2 to 3 days, unless you're in an ambiguous situation where like, well, I want to do one, it's low, I don't think they need antibiotics, but I'm kind of nervous. I'll do one in 6 to 12 hours. And if that's negative, I'll feel really comfortable that we're not giving antibiotics. So with that, I will stop and go through a couple of cases. All these cases are people that I've seen. So a 65-year-old female recently discharged from the hospital, had an acute MI, got a stent. She comes in with shortness of breath over the last day. She has a cough, productive of a little bit of sputum. It's hypoxic at her facility, no fevers or chills. She does have leukocytosis, mild elevation of lactic acid, mild acute kidney injury. Chest x-ray shows interval left greater than right, new opacities, especially at the bases. Is it edema? Is it an infection? So the question is really, is this sepsis with elevated lactic acid and acute kidney injury, which needs antibiotics and 30 mLs per kilo, or is this heart failure with some renal hypoperfusion? Well, her Procal was less than 0.05. And so the ED gave her a dose of antibiotics, but the medicine team did not. And her EF was like 30%, and she had new onset AFib, and they gave her a bunch of diuretics, and by the next day, she was way better. So Zosyn and 30 mLs per kilo would not be the way to treat this patient, and the procalcitonin is useful for helping us sort that out. 77-year-old female with dementia, O2-dependent COPD, presents from a long-term care facility with altered mental status, increased O2 need. COVID's been in the facility. She's got crackles on exam. She's febrile. Her white count's 8. She's got biohazy opacities, maybe developing consolidations. Her PCT is 0.13. So this is a little iffy. To me, this sounds a lot like COVID. I wouldn't generally start antibiotics, but if I didn't, I'd repeat a Procal in 6 to 12 hours. If you said, well, I'll start tonight and repeat tomorrow morning, and if it's still low, we'll see what my COVID test is. And as long as PCT is low and COVID's positive, we'll stop the antibiotics. That would also be a reasonable strategy. That's actually what she had. She had COVID. And then last case, I always like to throw in cases where it wasn't useful, just to show you how you have to kind of think through these things. So it's a 29-year-old female who was transferred to our facility. She had a rash, she had fever, joint pains, renal failure, headache, confusion. She had a macular rash, multiple areas of synovitis. She didn't have neck stiffness or other exam findings. Her white count was elevated. Her creatinine was elevated. She had blood and white cells in her urine. Her inflammatory markers were high. Her complements were low. And her procal was 6.5. And so it looked like lupus. But if you read the literature on lupus, procalcitonin generally isn't supposed to be elevated in lupus. At least that's what I was able to find. And so she got covered with vanco and ceftriaxone because of her fever and headache. And we did a big workup. Didn't find anything. The rheumatologist initially said it's not lupus, but then when the NAs came back, they're like, well, yeah, I guess it is lupus. And she had lupus with cerebritis. And so her procal on day 4 was actually like 4 still. But because she was much better, we had an alternative diagnosis. We said, well, we'll stop the antibiotics and just watch. And she did fine off of antibiotics. And so that's where you really do have to put the lab values in context of the patient. Did you really need those antibiotics to start out with? Probably not, but I think even without Procal, she probably would have got treated with them until we ruled infection out. So with that, I will stop and take questions.
Thank you, Dr. Van, for your presentation. We'll now go ahead and start the live Q&A portion of the webinar. If you have a question you'd like to ask, please do so now. Just click on the Ask a Question box located on the far left of your screen. All right, your first question is, as an antimicrobial stewardship pharmacist, how can I motivate physicians to actually integrate procalcitonin ordering and interpretation to their practice at my hospital?
Yeah, good question. So how do you get people to use it? Because this is really the tool of the hospitalist, less than the ID doctor. Because the patients we see are very complicated and difficult sometimes to interpret. And so I think the way to do this is to build this into standardized protocols, whether that's you build it into your community-acquired pneumonia, whether you build that into your exacerbations of COPD order set, your sepsis order sets. And then I think it helps to have a champion for that, and then utilize that to utilize that person or those persons to move this forward. So for our facility, we use our pharmacists a lot. And so we developed basically some guidance on exacerbations of COPD. We did a bunch of education for our clinicians. We put this, Procalcitonin in the order set, developed an order set. And then our team-based pharmacists actually look at procalcitonin and say, hey, the procalcitonin is really low. Can we stop the antibiotics? And so I think one thing you have to do is educate people, but you also have to sort of remind them, because education doesn't stick. And so it helps to build it in that this is how we manage things. And these are our guidance. So you have to make people aware, build it into their practice, and then remind them that that's their practice. And eventually they kind of learn that that's how we do things.
Great, thank you. Okay, your next question. Is there any data that supports the role of PCT biomarker use in changing antimicrobial agent and or dose?
Yeah, I don't know for dose. Where you would use it to change antimicrobial agent would be perhaps that non-declining procalcitonin. Now, I would not tell you to routinely change. There was actually a study, a randomized trial, where they randomized people who had non-declining or rising procalcitonins to either usual care or escalation of antibiotics and additional imaging. They found there was no benefit, and there was actually harm to routinely escalating antibiotics and doing imaging, which to me is not surprising because, again, we're treating lab values, not patients, and we're doing things that don't necessarily need to be done, like giving contrast dye and broad spectrum antibiotics. And so you really have to make that as an individualized patient decision in the context of the clinical scenario. And so that rising or non-declining might be a place where I think about it, but I'd want to make sort of an intelligent decision based on my reevaluation of the patient. And I wouldn't really look for a non-declining in the first 24 to sort of 36, 48 hours, because it'll sort of peak out there at 12 to 24, at 12 hours-ish. And so you may not catch quite that peak. And so it's really at that 36, that 72, 96 hours that you're like, we should start to see some improvement at this point.
Okay, your next question. During the recent Sepsis Alliance 2-day summit, there was no mentioning of PCT by any of the presentations that I watched. So why is there still so much resistance to use of the biomarker despite all of the many publications showing its benefit, both in sepsis and lower respiratory tract infection?
Yeah, good question. So there are, that's a great question. I think part of the problem is for ID doctors, they have found it not super useful. And that's because of the bias of ID patients, and that nobody calls us about simple, easy to sort out patients. And like I mentioned, this is really more the hospitalist or the intensivist tool. The studies have generally been done in Europe. Now, why Europe would be so much different than the US, I don't know. I think there's also people look at the New England Journal study and say, oh, it didn't work in the US, but don't understand the differences between that population and all the other populations studied. And so I think there's a combination of, bias against maybe some of the European literature, some ID doctors who are strong voices who are non-believers. But, my opinion is we need tools to help us make better decisions with antibiotics. Is it a perfect tool? No, it's not perfect. But, what else do we have? Show me a better marker with better data, because there just isn't one right now. I don't know why people talk about ICU stewardship. I mean, if we treated everybody with 5 days of antibiotics in the ICU, maybe we don't need procalcitonin, but that is not my experience in my ICU.
Okay, thank you. Now, this next question, has PCT utilization increased since COVID, now directly related to COVID or possibly other factors?
Oh, it's hard to know if it's increased. I would say it's routinely measured on admission. I would say our clinicians use it in helping in making their overall decision about whether we need to give antibiotics or can withhold. I don't know that it's increased. It's really hard to say, mostly because our patient-like census has fluctuated so much with COVID, and then we had a lot of COVID, and then we didn't have very much, and it's kind of gone up and down. I would say it's routinely used in our COVID patients, but I would say it's pretty routinely used at our institution in general.
Okay, now other than the confounders you mentioned causing PCT to elevate, are there any others?
Those are the ones that I'm aware of. There may be other confounders. I didn't put together an exhaustive list. I don't know of exhaustive lists, but that's a list I've sort of accumulated over time.
Okay, great. Thank you. Now, next question, how is PCT cleared? Does renal impairment have an effect on decreasing levels?
Yeah, it can have some effect. It is cleared somewhat renally, maybe some through dialysis, and that's where it can be a little difficult to interpret in some of those ICU patients. But again, really low, useful, high, useful. It's that sort of 0.25 to 1-ish, 1.5, can be a little hard to interpret. But generally, I've interpreted it, as I normally would, keeping those sort of nuances in there. And nobody really knows the answers to how much or when, or that just, as far as I know, isn't available. There's a nice review of the literature that was published in Clinical Infectious Disease a couple years ago addressing this topic, sort of summarizing how to interpret procalcitonin in the setting of renal dysfunction.
Okay, great. Thank you. Now, among the physicians utilizing PCT today in the U.S., what percentage would you say are familiar with the cutoff values and recommended actions for each of the cutoffs?
Oh, that's the difficult part, right? It depends by center how well people understand it. And that's where it's actually even difficult when you bring it on in your lab and that you have to have a discussion. Which value am I going to flag as abnormal? Am I going to flag the 0.25 or am I going to flag the 0.5? Is it used for sepsis? Is it used for lower respiratory tract infection? Because, the lab doesn't know which it's being used for. So we flag it at anything over 0.1, because 0.1 is sort of where you might think about it, maybe in your bad COPD exacerbations. But it's highly variable. And my sense is that nuance is sometimes lost on people.
Okay, thank you, Dr. Van. We have time for just a few more questions here. Now, you have very nicely stated that PCT is a tool for the hospitalist. Now, what about the EM practitioner?
Emergency medicine, so what I would say is that's where most of the studies were actually done. Were done starting in the ED, where they did PCT in the ED and decided whether they should start antibiotics. We have not utilized it quite that much that way, just because our ED doctors, if it takes more than 5 minutes, tend to think it takes too long. And so they want a result very rapidly. But I think it has great utility in the ED, and that's actually all those lower respiratory tract infections, except for like the HAP and the VAPs and things like that, were done in patients presenting to the ED with lower respiratory tract infection.
Great, thank you. Okay, let's go ahead and wrap up with this last question. And how do you have PCT ordered in your hospital? Is it independent of other tests or attached with antibiotic order, et cetera?
Good question. So we have it generally independent. Now, it's built into our order sets for pneumonia and COPD exacerbation and sepsis. It's part of some of our automatic sepsis protocols that it gets measured. But just because of how people order it, we tend to build it into order sets or these protocols for those things. You can't really, so it is with the antibiotics in the sense that it's with the order set with the antibiotics, but along with everything else. But I think it's important that you put it with those things, right? If you have a sepsis protocol, having Procalcitonin be a part of that would be a reasonable decision because it has some utility there if your site decides that's something it wants to do.
Thank you again, Dr. Van. Do you have any final comments for our audience before we close today?
I don't believe that I do. I'd encourage, if you're interested, to read some of the studies that I cited in my slides here.
Great. Thank you again for your time today and for your important research. And we would also like to thank LabRoots and our sponsor, Thermo Fisher Scientific, for underwriting today's educational webcast. Before we go, I'd like to thank the audience for joining us today and for their interesting questions. As a reminder, any questions we did not have time for today and those submitted during the on-demand period will be addressed by the speaker via the contact information you provided at the time of registration. This webcast can be viewed on demand, and LabRoots will alert you via email when it's available for replay. We encourage you to share that email with your colleagues who may have missed today's live event. Again, thank you, Dr. Van, and until next time, take care. Bye-bye.
Thank you.